Hello, everyone. I apologize in advance because you're going to hear my voice on Tuesday, and hopefully, if life continues as planned, you never know, uh, you will hear my voice on Thursday, and then Friday, and then probably on Saturday, some of you, and maybe even on Sunday. We'll see. So, apologies in advance. My building is offering earplugs today because they're doing fire alarm testing, and I thought I should bring them and give them to you all in case it'd be handy. You get sick of hearing my voice. But I couldn't resist the urge to have the honor and pleasure to discuss with my a case that presented by my dear friend Yaz. And we're going to do things a little bit differently today. We're actually going to have each aliquot be an aliquot tackled by you all in breakout rooms. And the only thing that I know about this case is that it is hypothetically a bread and butter case. Now, I say hypothetically because you could never trust a CP Solver's team member about their ability to say bread and butter. That's the only flaw we have. We always think that if you go by Kirtan's level of what bread and butter is, a perinodal neuropathy is just a simple case, quote unquote. So, but I think I trust Yaz with acumen more than I trust kirtans, for example. um, so I will try to make breakout rooms for as many as about aim for like 4 people per group. So let me get working on that. But in the meantime, I'll pass the mic to my dear friend Yaz to say hello.
Hello, everyone. I'm so happy to bring a case that Dr. Ravi gave me. And it's very bread and butter, something that I've noticed from participating in this amazing project, Maima, Bettina, and Amanda's, the CRC, the Case Review Committee, is that when I have this privilege of meeting you all, some of them say, hey, but I don't know if I can have more cases. I don't know if I should present this because it's not that interesting. And friends really, I think that I mean, I love Kirtan cases. I love to hear him talking and talking and talking about all of these different antibodies. But if you want to present a case note and it's, I don't know, kidney injury, infections, I love infections, um, pneumonia, or whatever you want, like a stroke. We also need to end neurophobia. Like, please bring them. And this is for us to exercise our critical reasoning. So, yeah, that's something that I would definitely like to everybody to know. And oh, by the way, Eid Mubarak to everybody that celebrates it. And back at you, Rabbi.
I love you. You're so conscious of the world. Yes, it's Eid Mubarak to all of you who are celebrating today. And thank you to all of you who are turning your video on, especially my dear friend and former Sabai Sohail, who's joining. Hello, Sohail. Nice to see you here.
Nice to see you, Dr. Ravi.
Oh, the pleasure's all mine, my friend. Alrighty. So, Deborah is kind enough to be scribing today. Thank you for jumping in, my friend. I'm not sure if Jimena is here. I don't see her. Um, but Yaz, why don't we hear the first aliquot? And after we hear it, I'll pause, we'll go into breakout rooms, and then we'll reconvene a few minutes later.
Perfect. I can give you the chief complaint, and if you want, I can give you the HPI.
Yeah, let's see what you got.
Perfect. It's a 57-year-old female with altered mental status. Should I
Awesome.
keep going?
Yeah, for the sake of time, why don't we get the
Okay.
HPI?
Okay, so this patient was brought from the clinic's ED, and because of mental status, and when we arrived with her, she states that she did not remember how she ended up at the hospital. When asked about her symptoms, she mentioned that she started 3 days ago with fever and myalgia, that she referred to this as body aches. Additionally, she mentioned that she presented cough and chest pain that exacerbated with deep inspiration. She also reported drenching night sweats and weight loss for many months, and reports ongoing anorexia, nausea, vomiting, and diarrhea that had persisted for weeks. And this is how we start the story of our 57-year-old patient.
Awesome. So just to clarify before we go in breakout rooms, it seems like we're meeting her in the emergency room.
Yeah,
She has just been brought from another clinic.
Exactly.
And she doesn't remember how she got here, but she's able to tell us that she's had a subacute syndrome of night sweats, GI symptoms, layered on top of 3 days of fever and cough. Is that right?
That's right.
Awesome. And we still don't yet know, you haven't told us yet, what happens as she becomes altered, right? That's not known yet.
That's not enough.
Okay, all right, terrific. So I'd be really curious what you all start to think about in the breakout rooms. I'll pause the recording. If you cannot go into a breakout room, don't worry, just hang out in the main room. And we'll aim for about a 3-minute conversation, so like a few minutes per person in the breakout rooms, and I'll see you all very soon. Hope you guys had a good time. It seems like nobody came back early, so hopefully you all were having rich conversations. I think the care of this patient in real life would be very complicated because of one simple fact, and that fact is that altered mental status for most people tends to be the dominant abnormality. And so I think having to try to solve a problem where altered mental status is the tail end of a evolving syndrome makes it very, very tough. And so I think in the moment, when you're dealing with a subacute tail of systemic symptoms, in the context of what seems to be an acute syndrome, I think you would probably be ignoring the subacute tail and trying to understand the acute syndrome before you. So I don't think many diagnostic reasoning hypotheses would be happening about what the subacute syndrome is, simply because altered mental status is too pressing to move forward. So I think really understanding her altered mental status in more detail will allow us to make progress. And right now, authentically, I think it is impossible to make sustained progress on anything in the background. So what would I be realistically doing? I would be keeping note of this constellation of things to solve after I understand the altered mental status better. So this is noted, but not worthy of a deep investigation right now. So I'm really curious, Yaz, what more information you have for us to see how we can link it back to this.
Of course, and you will understand why she didn't know how she ended up in the hospital after the second article with the past medical history. For her family history is unknown. She takes no medications. She refers no allergies. And for her social history, the patient refers that she lives with her cousin sometimes, but usually lives on the street.
Hmm.
And she also mentioned that she uses heroin 1 to 2 times per week. She injects it. And that will be it for the second article. It's a very small, but I think
Yeah.
it's strong in this case.
It's amazing, Yaz, how much you've really the context of the patient and where they're lived and what their exposures are profoundly important in this case. And so I think this is a great exercise to see what our thoughts were before and what our thoughts are now. So let's hop into another round of breakout rooms and we'll see what you all come up with and how much progress you can make. We'll see you all in a little bit. All right, welcome back, everybody. I think the deliberate layout of Aliquot and Aliquot 2 is so a lot informative, and I think it goes to show you how powerful it is to try to solve the current problem, to keep the context, which is the subacute symptoms that she's having, and also the social context, really, really important. And unfortunately, she has criteria for all the scary causes of altered mental status. Well, so when you're trying to prioritize altered mental status and think of the most life-threatening causes, those life-threatening causes are the ones that begin the most abruptly. And they're the 4 S's: seizure, stroke, hypoglycemia, and substance intoxication. These are the 4 S's that prioritize our thinking when we first see a patient with altered mental status, which is why we will always think of giving sugar to the patient. We will always think of giving naloxone for the possibility of opiate intoxication. We will always wonder if the patient is having a debilitating stroke, usually hemorrhagic over ischemic, in the context of altered mental status, and we will always wonder if there's a seizure. By virtue of her opiate use disorder, she is at risk for all 4 categories. She's at risk of heroin intoxication. She's at risk of nutritional hypoglycemia. She's at risk of a stroke, hemorrhagic or ischemic via multiple different mechanisms. And she's at risk of seizure through traumatic brain injury, potentially, and other mechanisms. So what would happen right now when you meet the patient? You would immediately get a finger stick glucose, And then you would closely assess for the possibility of opiate intoxication by looking at the respiratory rate and by examining the pupils. It's going to be very important not to liberally give this patient Narcan just because of altered mental status. You really have to have a strong case for opiate use disorder and an opiate overdose to give the patient Narcan. Because if she has another cause of altered mental status and you give her Narcan, you're only going to precipitate discomfort from her end without the return of investment. So to be concrete, if she has a large intracranial hemorrhage as a result of an intracranial trauma and is altered for that reason, if you give her Narcan, you're only going to make things more complicated. You'll increase her blood pressure and you may worsen the problem. So risk for opiate overdose does not mean it's happening. And I think the downsides of opiate reversible are noteworthy and really important to keep in mind. So a finger stick blood sugar is really important to do in the circumstances right away, as is the judicious use of opiate reversal, only with accumulation of more and more suspicion, primarily through the pupillary exam and through the respiratory rate. Those are going to be key. If hypoglycemia and opiate overdose are not present, I think it becomes even more important to think about the two S's, stroke and seizure. Within the stroke category, we talked about hemorrhagic stroke, but I think this possibility is really important to examine, especially in the context of her subacute symptoms. Subacute infective symptoms in a patient with injection drug use immediately opens the possibility for a bacterial endocarditis. The other major subacute cause of infectious syndromes is the chronic viral infections like HIV and hepatitis C. So in this patient, I think no matter what other data we receive, we should probably order tests for all those viruses, HIV, hepatitis C, and hepatitis C, and when you're suspecting endocarditis, to obtain 3 blood cultures. The practical realization to the care of this patient will also include the reality that with long-standing injection drug use, it becomes very difficult to get IV access. So preparing for complex IV access by ultrasound guidance or other techniques for this patient is really, really important. So what are we going to do? We're going to think about Narcan, but we're not going to give it liberally. We're going to get a finger stick blood glucose. We're going to get IV access with 3 blood cultures. We're going to look very, very closely for opiate overdose, but none of these are important as 2 really, really important things. Patients with opiate use disorder have a high rate of being stigmatized by us. If you don't treat this patient with courtesy and with respect and with giving her a lot of space to be herself, you're going to lose the ability to take care of her. And so I think recognizing the stigma that comes with the opiate use and understanding the many reasons why patients go to substances is really important as you care for her. Just as important is to realize that while you are taking care of her, she's not going to be using heroin, which means that she's probably going to go into opiate withdrawal. And managing opiate withdrawal before it becomes a big problem is really, really important. So she has a problem, which we need to address, but she has 2 other problems which are also important: the stigma associated with opiate use and the risk for opiate withdrawal. The COWS assessment, COWS, is a tool that is used in the United States to help you diagnose, treat, and manage opiate withdrawal. And I think that'll be really, really important in this person. Hopefully we made some progress, Yaz. What do you have next for us?
Yeah, I think you definitely made an amazing progress. And I think having this information whenever our future interns get to that ED and have to treat this patient, they will definitely know what to do. So for the vital signs, we have a temperature of 37.9, heart rate of 120 20 beats per minute, blood pressure 130/80, respiratory rate of 30. In general, we see a chronically ill appearing, cachectic, weak patient. She can answer your questions, but she looks tired. There's bitemporal wasting, white plaques in the oral cavity that can be scraped off are found too. And her cardiovascular, she's tachycardic. There is normal S1 and S2, no murmurs. On her respiratory examination, there are bilateral crackles that can be heard higher on the right than the left. There is a poor inspiratory effort. Her abdomen is soft, remarkable. Like there is no pain, no rebound. On her neuro examination, she is oriented. She knows who she is. She knows what day it is. She knows she's in the hospital. She just didn't know how she got there, how she was brought here to the hospital. There are no focal deficits. There are no rashes appreciated, although her skin looks dry. Do you want more information?
Yeah, since we're doing this breakout room format, maybe we can get the initial labs or whatever you had next, just to have more to work with when folks go into breakout.
Perfect, perfect. So I do have the basic labs.
Yeah, let's do it.
For her white blood cells, she has 1.83, 71% neutrophils, 22% lymphocytes, and her hemoglobin was 9.7. Her platelets were 377. BUN creatinine was 40, and the creatinine was 1.08. There was an anion gap 18. Sorry, I'm going to give you ABG. The ABG is pH of 7.6, a PCO2 of 20, PO2 of 75, and 19 of bicarbonate on 4 liters nasal cannula. That's when she was on 4 liters nasal cannula when she got this ABG. She got an alk phos of 124. Her AST, ALT was 87 and 27 respectively. She has a lactate of 3.4 and a urinalysis that was negative.
Terrific. Super, super helpful. I'll just give folks another 10 seconds here to absorb this data and maybe summarize the pertinent abnormalities. So she's borderline febrile, tachycardic, tachypnic, and I think we missed her O2 sat. Yeah, do you remember what her O2 sat was?
I don't have it. Like
Oh,
for some reason I don't have it, but
no.
I don't.
No problem. And then we see that she has white plaques on her oral cavity that can be scraped off.
Yeah, oral cavity. She has white plaques that can be scraped off.
Perfect. And then she has bilateral crackles.
Mm-hmm.
She has leukopenia, anemia, elevated liver enzymes, and a hypoxemia with a high AA gradient.
No murmurs, Dr. Alec. I'm seeing the questions.
Awesome.
The anion gap was 18.
Okay, alrighty. Let's go forth and nerd. I'll open up breakout rooms for you and we'll reconvene in a few minutes. All right, lovely people, welcome back. Before we move forward, let's sort of reflect on where we were before. We were really focused on her altered mental status, and we were thinking about the 4 S's. Is there a syncope? Is there a seizure? Is there stroke? Is there a substance, or is there sugar? And her sugar is normal. And I'm really glad we didn't just empirically give her naloxone, because her respiratory rate is 20, her pupillary exam is normal, and she appears to not have a deep altered mental status. In fact, when you look at how sick she is compared to her altered mental status, it's probably that her brain is just not working perfectly because her lungs aren't working and she's so sick otherwise. So I think after we talk with her, we really de-emphasize just how much we need to focus on her brain. And now we're trying to figure out what else to focus on. And gosh, there is a powerful signature to the possibility of HIV infection here. And I just wanted to share how important it is to get that test from the beginning when you hear about injection drug use, but to really suspect it. And I will show you a visual. when we're trying to see if somebody has HIV, it's really important to pay attention to these pre-test clues. Patients who have weight loss, all of them should get HIV testing. Patients with prior sexually transmitted infections. Patients who have thrush, which is what she has on her oral exam, as plaques that can be scraped off. If you see Kaposi's sarcoma or if you see lymphadenopathy. Leukopenia, especially lymphopenia, is a really important trigger, as is proteinuria. GGOs often raise concern about PJP. So here she has low weight, thrush, leukopenia, and probably has GGOs based on the fact that she has bibasilar crackles. All four criteria for HIV. And I think it's really hard not to worry that this person has undiagnosed HIV infection. And based on the degree of lymphopenia that she has, she probably has advanced HIV infection. So I think everything else, all the other abnormalities, really fall to the wayside, and you start to analyze this patient as having presumed HIV. And so if you remember what else she has, while I give Deborah the whiteboard back, is she had lung stuff. Lung stuff plus HIV basically means routine bacterial organisms like strep pneumoniae as the most important treatable cause, but with early consideration of PJP. So from the lung perspective, she would probably be getting community-acquired pneumonia treatment, but would probably be also getting PJP treatment or PJP testing. By the way, Julia, I just saw your partner, and that was really cute and very endearing. Uh, anyway, so that's the lung stuff. The brain stuff is really important to think about here. It's probably unlikely that somebody with altered mental status to this degree has bacterial meningitis. She's not that sick, but I think thinking early about cryptococcal meningitis is really, really important. And in terms of the liver stuff, anytime you see hepatitis in a patient with HIV, you should think two things: MAC, Mycobacterium avium intracellulare, and syphilis. Both of them can cause hepatitis in patients with HIV. That's an organ-based progress. Altered mental status, cryptococcal antigen. Lungs, PJP testing and CAP treatment. Liver, syphilis, and MAC. But those are rapid associations in real life. All the other data, she's got all this other stuff, I think is not as important as really understanding the crux of the infectious disease testing here. And it's probably best not remembered by system, which is what we're doing it in this patient, but always to think about it in general terms. And these are the routine blood tests we get in patients with HIV. We always look for the other STIs via blood testing. We always get blood cultures for bacteremia. And then we always get an AFB blood culture for MAC and a cryptococcal antigen for cryptococcal meningitis. Here, I would also consider getting an LDH and a beta-D glucan as tests for PJP. So how do we make progress in this moment right now? I think the cryptococcal antigen and the PJP testing are really important, but we should treat this patient for presumed bacterial infection because that is way more common than any other kind of infection in HIV. So I would probably be treating her with ceftriaxone and doxycycline initially while awaiting further data. She probably would also be getting some hydration as well. All right, Yaz, what do you have in store for us next?
First of all, I have to say that I'm very thankful to be able to hear this masterclass of how to take care of patients that come with complex backgrounds and with high probability of having very complex infectious diseases. Not because I like ID, but because it's important to know them. Again, I have some imaging for you. We had a CT head with contrast. There were no intracranial findings, and an echo with no valvular vegetation seen. We've had a CT thorax with a multifocal airspace disease, dense consolidation in the right lower lobe with air bronchograms, and the similar findings in the lingula and right middle lobe. There were no evidence of embolism. I can share my screen because I got the image. I don't know, like I can share it. Oh, can somebody let me share my screen?
Yeah, you should be good to go, my friend.
Perfect. I will share the screen too. I will show you this. Again, apologies if like it's not very good resolution, but this is what we saw. I just need you to see this image.
Yep. Yeah.
This is what we found. So I have the Aliquot 5, which has a little bit of story of how this patient evolved.
Yeah.
And okay, so before jumping into the microbiology information we had. So for the first 2 days, she got all this imaging and basic labs, CT imaging, reflected pneumonia, unclear underlying etiology in this first 2 days. So she was starting a broad spectrum antibiotics with bank cefepime and flagyl. ID was consulted and microbiology studies were sent. These were obtained on day 3, except for the HIV. Now I think I'm revealing a lot here, but it's important for me to just keep everybody clear that here in Dr. Rabih's hospital, like HIV is also sent in the ED. For microbiology, we had Legionella, Galactomannan, quantiferon TB gold, beta-glucan, Gisevirus PCR, Toxo, CMV, VDRL, hepatitis C and B antibodies, all negative. We also had acid-bacillus sputum and blood cultures negative. The blood cultures were positive for gram-positive cocci in chains and pairs. There's a sputum culture positive for Pseudomonas with mild and moderate growth. The PCP stain was negative. A cryptococcal antigen was positive in a titer of 1 to 5. The strep pneumo urine antigen was positive. The beta-D-glucan was 81, was positive. And CSF studies and cultures were negative. Do you want to keep on going?
No, I think this is great, Yaz. I think yeah, let's just do one final breakout room to see what folks are thinking. I think you're getting us very, very close to a diagnosis, and we'll reconvene in a few minutes. All right, y'all. Let's reflect on where we started. We heard that this patient had a subacute inflammatory syndrome and was altered. And then we learned that she uses heroin. And now we've learned that she has a respiratory problem characterized by consolidations. She has gram-positive cocci in chains and pairs in her blood. She has a positive cryptococcal antigen. Thankfully, she has negative MAC and AFP blood cultures. And so while we don't know her HIV test, I think there's overwhelming evidence that she's HIV positive based on many of the things that we've talked about. And I think while HIV perturbs your immune system to cause all sorts of fancy esoteric things, I think this case is a humble reminder that the most common complication of HIV perturbing the immune system is really bad common infections. And the most devastating thing that this person has is strep pneumoniae bacteremia. The reason we know it's strep pneumoniae is because gram-positive cocci and change in pairs suggests strep, and she has pneumonia. And we also know that her urinary antigen is positive. So I think this patient has invasive pneumococcal disease. And strep pneumoniae bacteremia in the modern era with pneumococcal vaccinations is becoming exceedingly uncommon. But the rate of bacteremia in patients with HIV is about 10-fold higher than it is in normal populations. So if we put this visual in front of us of the infections in patients with HIV, you'll see that infections complications can result directly from HIV itself, from parallel STIs like syphilis, from routine infections that affect everybody like strep pneumo, or from infections related to the immunosuppression. And here is a powerful example of how patients with routine infections, invasive strep pneumo here, that's overwhelmingly the most common. What else have we found? Thankfully, we haven't found any evidence of any other STIs so far. We found cryptococcus in the blood, but not quite in the brain, which is a very controversial subject. We haven't found Mycobacterium avium, as the blood cultures are negative for that. And we aren't sure if the patient has PJP because she has mildly elevated beta-D-glucan, but her pulmonary imaging is not suggestive of PJP, which would usually be seen as bilateral ground glass opacities. So I think that in this patient, she probably will receive prolonged beta-lactam antibiotics for strep pneumobacteremia. Thankfully, she doesn't appear to have suffered other consequences of strep pneumo, including meningitis. The very interesting thing about strep pneumoniae is, unlike many other gram-positive organisms, the rate of endocarditis with strep pneumoniae is really low. It's about 1 to 3%. It is cool enough that it's described under the term Austrian syndrome, but that usually occurs in patients with alcohol use disorder, not in patients with HIV. So an TTE might be considered, but is not necessary in invasive pneumococcal disease. I think it'll be a really interesting dilemma to see how cryptococcemia is treated without overt cryptococcal meningitis. Patients tend to evolve into cryptococcal meningitis if not treated early and aggressively, so that's certainly part of the calculus. It's also going to be very interesting to see how highly active antiretroviral therapy is instituted here, given the potential risk of oh, maybe I was wrong. Alec, you might have. I just saw your note in the chat. I thought it was high, but I might have completely made that up. Anyway, she definitely has strep pneumobacteremia. I'm not sure what else she has. I suspect she has HIV. But yeah, I'll pass the mic to Yaz. What do you have? What diagnostic data finally unlocked the case for you all?
Yeah. By the way, I have to be very clear. What I'm going to reveal, we already had it from the first article, but I didn't reveal it just for the sake of the exercise,
Yes,
right?
of course.
We got her HIV studies. Her HIV antigen antibody was positive. HIV viral load was 16,000. Her CD4 count was 3. So in this patient, more history. After getting all these results, the patient was previously on fluconazole as soon as they saw the oral thrush on 100 milligrams and had an increased dose of 400 milligrams. Because I'm going to give you one of the teaching points I had prepared. She was treated as cryptococcemia. For those individuals with non-CNS isolated cryptococcemia, a positive serum cryptococcal antigen titer is more than 1 to 8, or if they have urinary tract or cutaneous disease. And the recommended treatment is anisole, being fluconazole or itraconazole. But it's all immunocompromised patients require treatment, indifferentially, since they are high risk for development of a disseminated infection. And as you mentioned, I think you read I promise I didn't give Rabih my teaching points, because one of the key aspects on the management of cryptococcal when you find an immunosuppressed patient is look for meningitis. So a little bit more history on this patient, and the diagnosis in plural is that she was also put on Bactrim as prophylaxis for PJP. 2 days later, the results of the CSF panel were obtained and results were negative, but her AST increased to 271 and her ALT increased to 200. There was suspected drug-induced liver injury, so Bactrim was changed to atovaquone. She was also put on ceftriaxone for the bacteremia, for the strep pneumobacteremia, her second diagnosis. And after 5 days, her strep pneumobacteremia cleared. And day 9 of first aid, LFTs were unresolving, suspected secondary to fluconazole, but we weren't able to stop it as it was needed to treat cryptococcemia. She was started to in Biktarvy and started to close monitoring for iris. And this is not everything. After 2 weeks of treatment, there were new interval fevers, spikes that developed. The patient again had an increased work of breathing, ongoing chest discomfort, and a repeat CT imaging was obtained. And let me show you what happened to this lungs. That's why I wanted to show you the first CT. Let me show you quickly how it looked after 2 weeks. Let me see, is this one? That was the first one. And this is how the patient's lungs after 2 weeks. This was an acute cavitary pulmonary disease suspected to be secondary for Pseudomonas, presumed to be a reactivation of a subclinical infection. And that's basically in summary. Our diagnosis would be cryptococcemia, drug-induced liver injury, an acute retroviral syndrome, a streptococcal pneumonia bacteremia, and cavitary pulmonary disease secondary to Pseudomonas.
Otherwise known as bread and butter by Yasmin.
I was
knew it.
I was starting to look at it like sourdough, you know.
Oh my gosh, I knew I shouldn't trust you. Now you have been elevated to Kirtan level of distrust. I will never trust you when you say bread and butter ever again. Can you all believe this?
What do you mean?
It's so funny. Congratulations, Yaz. You've been you've been Kirtan. Gosh, I think this case is full of learning. Thank you for emphasizing some of the key points, which I think were really, really powerful in this case. And I would just emphasize that if you're taking care of this patient, I think the high yield things in real life are to not give somebody with heroin use Narcan just because they're altered. You have to have more suspicion of opiate use. I think it is very powerful how much you can suspect HIV based on objective data alone, including weight loss, oral thrush, leukopenia, proteinuria, and imaging findings. And I think the adage of a patient with HIV having many, many infections is really important to keep in mind. But that has to be tempered with the reality that the vast majority of patients most often have invasive bacterial diseases, more so than fungal, viral, and atypical organisms. And I think most of her illness and how sick she was probably driven by invasive pneumococcal disease, with certainly contributions from everything else she had. But let's not lose sight of the most common, and instead of thinking about infections and moving our thoughts towards unusual ones, it's really all about expanding our thinking to include unusual ones. Thank you, Yaz. This was really fun. I hope you all enjoyed chatting with each other in the breakout rooms. But the last word will go to my friend Parisa for the teaching points.
Thank you so much for this amazing case. We have a 57-year-old female who presented with altered mental status. We have the mixed mnemonic, and we know that the M is metabolic, infection, structural, and toxin. But when somebody is coming with acute syndrome like AMS, we need to pay more attention to this acute finding instead of addressing this other subacute symptom like the other thing this patient has. We know that most life-threatening causes of altered mental status are the 4 S's, and considering her past medical history, she was in the risk for all the categories: seizure, stroke, sugar, and substance intoxication was the 4 S's. We know that she might be in the risk for developing hypoglycemia because of the nutritional hypoglycemia, and she also might have a hemorrhagic stroke, over ischemic stroke. And she might also have a seizure because of the traumatic brain injury. The steps we need to take is checking her finger stick glucose. We need to also make sure about her opioid intoxication. We need to examine her pop pupil and her respiratory rate, and if they were raising our suspicious, we will give the patient naloxone. Otherwise, we will avoiding giving the patient naloxone because of the jeopardizing her situation she has. If these finger stick glucose and opiate intoxication are negative, we need to think about a stroke and seizure more likely. The other thing is important is providing IV access in this patient, and because she was using IV drug abuse, it might be challenging for having the IV access. We might need ultrasound guided to get his access. We also need to take 3 blood culture from her, considering the suspicious for infective endocarditis. We also need to go through other chronic viral infections, including HIV and HCV. When the symptom rising our concern for HIV are usually weight loss, prior STD, Kaposi sarcoma, and leukopenia and lymphopenia, and proteinuria and GGO. The organs we need to exam is the lung because of the community-acquired pneumonia and PJP. For the brain, we need to consider Cryptococcus meningitis. For the liver, usually patients with HIV need to be tested for MAC, avium, and syphilis. The routine blood tests in HIV are usually STI and other blood cultures, and we need to also check FAP in the blood for checking the MAC and cryptococcal meningitis. And also for this specific patient, we need to check LDH and beta-D-glucan for examining the PJP. The treatment we need to take empirically are ceftriaxone and doxycycline plus hydration. We know that common infections are more common in patients with HIV, specifically a streptococcus pneumonia. Rate of bacteremia in HIV is 10 times higher than normal population. But we know that the streptococcus pneumonia has lower risk of endocarditis. Vast majority of patients with HIV usually have invasive bacterial diseases more than atypical and fungal infection. Thank you for this amazing case. I learned a lot today.
Thank you so much, Parisa. You're an absolute sponge. I love how you were able to really keep it focused on the relevant stuff initially and not so esoteric. So you really turned Yaz's case into a true better and better one. Thank you so much. All right, y'all. I had a great time hanging out with you all. It's a little bit out of my usual routine to do so on Tuesday, but I was thrilled for the opportunity and look forward to seeing you all the rest of the week. Enjoy the rest of your day. Bye.